very good afternoon, everybody. Pitching me about pre-lunch on second day after so many good talks is like asking you to see a documentary after Bahubali, I guess. As though, even though my slides are not as scintillating, titillating, or very visually exciting, I try to present today's topic, which is Polymyxin B, what, when, and how much, making the basics very clear for a clinician, because this is a fairly new antibiotic that we're starting to use again. I'll start with the pharmacology or the chemistry of polymyxins. These are cationic polypeptide molecules that have been there since 1940s. They have fell into disfavor from that point in time simply because of their high toxicity profile. Like the earlier speakers mentioned, we are reaching a period where there are very few antimicrobials in the pipeline, and we have a lot of MDR and XDR drugs, and thereby we are going to that era where we are seeing if we can use polymyxin B and polymyxin E, which is colistin, to salvage our patients in the ICU who have extremely drug-resistant organisms infecting them. Polymyxins are basically fermentation products of the bacteria Penibacillus polymyxa. There are 5 different types of polymyxins available, but only 2 are clinically relevant to us, which is polymyxin B and polymyxin E, that is colistin. For many years, colistin and polymyxin were thought to be very similar because they are derived from a common source. They have a very similar spectrum of activity and they have the same biochemical structure almost well. But in the last few years, there have been a lot of in vitro studies looking at the pharmacokinetics and pharmacodynamics of these drugs. And we now see that in terms of disposition and potency, these drugs are different. Now, how and why they're different is because colistin is given parenterally as an inactive prodrug, that is cholistimethate sodium, and it is converted to its active form once it is administered in vivo, whereas polymyxin B is given in its active form. Thereby, there is a time lag between the availability of the drug to fight against the microorganisms when we give colistin, and that is the reason for the difference in potency. So, colistin differs from polymyxin B in the amino acid composition. Both have a polypeptide cationic structure, but if you see in position 6 in polymyxin B, there is phenylalanine. The single amino acid which is substituted by D-leucine makes polymyxin B as colistin. There's another structure that's interesting here that we have to note. They are the gamma diaminobutyric acid residues, or the DABs. Why these are interesting is we all know that the earlier speaker has mentioned that colistin has a detergent-like action. It disrupts the outer cell membrane. These diaminobutyric acid residues are what are responsible for that disruption. They go and bind to the outer lipopolysaccharide membrane and then break open so that the drug can enter into the cell. Once the drug enters the cell, it gets in contact with the inner membrane of the organism and then causes complete lysis of the organism. So the ones in red are the drugs, and that is how they displace the outer lipopolysaccharide membranes. So that is what polymyxins are about. Now, against what organisms do we use them as clinicians? Polymyxin B and polymyxin E are bactericidal against most gram-negative aerobic bacilli. That is the key word. So if you have an anaerobic organism, then we are not even thinking of polymyxins. They are most active against Acinetobacter, Pseudomonas, Klebsiella, E. coli, and Enterobacter. There are certain organisms that are intrinsically resistant to polymyxins. They are Proteus, Providentia, Morganella, Serratia, and Burkholderia. Against these organisms, any gram-positive bacteria like our MRSAs and Enterococci, and against anaerobes, we never use polymyxins. So their spectrum is essentially confined to gram-negative aerobes, which is Acinetobacter, Pseudomonas, Klebsiella, E. coli, and Enterobacter. So let us have a look at the pharmacokinetics. We all hate pharmacokinetics and pharmacodynamics, or at least I did that as a pharmacology student because I didn't know that there was so much clinical application or relevance to us when we administer drugs. What happens when we give polymyxin B? It becomes polymyxin B sulfate, and primarily polymyxin B is cleared non-renally. A very small fraction of this drug is cleared through the renal route. How is this important? This is important, one, because we are giving an active drug, so polymyxin B starts acting immediately. It is not cleared renally, thereby there is no need for dosage modification when a patient has renal failure. And because it is non-renally cleared, the attained urinary concentrations of polymyxin B are very low. Thereby, if you have a patient with lower urinary tract infections, polymyxin B is not a good choice. Now let us have a look at the pharmacokinetics of colistin. Colistin is given as colistimethate sodium, and this undergoes sulfomethylation to convert into its active form, which is colistin. The most important thing to note is once we give colistimethate, before even it's sulfomethylated, 67% of the prodrug is excreted non-renally even before it's converted into an active drug. Now why that is important? That is because this excretion of the prodrug happens via the renal route. If you have a patient with renal failure, we need to dose adjust simply because the prodrug is available in the serum for a longer period of time and thereby results in a higher concentration of colistin in these patients. Colistin as such is non-renally cleared, and because this prodrug takes some time to get converted into active colistin, there is a time lag, like I mentioned earlier, for the action to start. So based on these pharmacokinetics, we understand that we need a loading dose to achieve a good concentration in the serum. We cannot just start off with some 2 million units given TDS because there is a time lag of at least 7 hours between the infusion and the onset of action based on in vitro studies. Because it is renally cleared, it attains very good concentrations in the urine. So if you have a patient with lower urinary tract infections with drug-resistant bacteria, colistin and not polymyxin B is a good drug of choice. Coming to the pharmacokinetics, it is both polymyxin B and E have a rapid onset of action, have concentration dependent killing, and the PKPD parameter that best describes these is an AUC by MIC. But we should also note that these antibiotics have modest or no post-antibiotic effects. And especially colistin has a very short half-life. It has a half-life of about 4 hours. Now how does this matter to us as clinicians? It matters because it is very important for this drug to attain good MIC levels. And we also need to understand that because there is no prolonged post-antibiotic effect, it is silly to give once a day dosing no matter what the dosing is for these drugs. One of our earlier speakers mentioned that we need to also know the breakpoints given by both CLSI and UCAST. These breakpoints have been given for Acinetobacter and Pseudomonas, but not so much for Enterobacteriaceae. And it is important to note that the MIC levels for Acinetobacter are comparatively low than for Pseudomonas. For Pseudomonas, sensitivity is less than 2 MIC, intermediate is 4 and resistant is more than 8. Whereas for Acinetobacter, if the MIC is greater than 2, it qualifies as being resistant according to both CLSI and UCAS breakpoints. It means that if we are treating an infection with Acinetobacter versus that with Pseudomonas, our necessity to dose the patient with a higher dosage of polymyxin or colistin is more important because the MIC range is very narrow. So how do we dose polymyxins? Polymyxin B is administered it can be given parenterally, intrathecally or topically as polymyxin B sulfate. Colistin can be given orally as colistin sulfate, or CMS, which is colistimethate sodium, is available for IV. Both these drugs are available via the inhalational route. First, let us see polymyxin B dosing. All these dosings have been taken from clinical infectious diseases and are also recommended by Sanford 2016. The loading dose for polymyxin is 2.5 mg per kilogram over 2 hours. The maintenance dose, the first dose is given 12 hours after the loading dose. Then the maintenance dose is 1.5 to 2.5 milligram per kilo given over 1 hour, diluted in about 300 ml of NS because thrombophlebitis is very common with polymyxins as mentioned earlier by the other speaker. It's given BD. There is one study that has looked at a higher dosage for polymyxin B, which is a 3 milligram per kg. But it's not very validated, it's just a small trial, and probably we can look at giving a high dose of polymyxin B, that is 3 milligram per kilo, if we are dealing with patients who have deep-seated infections or with organisms where the MIC is more than 2. And for our understanding, 1 milligram of polymyxin B is equal to 10,000 units. And as been mentioned earlier, there is no need for renal dose adjustment and is not preferred to be used in lower urinary tract infections. Colistin dosing is a grey area. The more I read, the more confused I am also. This is adapted from Sanford. The loading dose is 2.5 because 2.5 milligrams per liter is the
minimum steady state concentration of the drug we want to achieve when we are using colistin into twice actual body weight. Now, there is a caveat because when we have very obese patients like 100 and above, it becomes very difficult for us to decide dosing. But Sanford says use the ideal body weight and probably use the lower end of the ideal body weight while deciding a loading dose. The minimum loading dose for colistin should be 6 million units. Anything less than that takes more than 48 hours for the drug to start reaching a steady state concentration in the serum. So, less than that is out of question. There are studies that have looked at 6 million units, 9 million units and 12 million units as a loading dose. But at this point, there is no strong recommendation saying this is a better dose, but definitely not less than 6 million units. For maintenance, we give 12 hours later, and this has to be renally adjusted. We give it BD if the creatinine clearance is less than 10 ml per minute, and as a thrice daily dosing if the creatinine clearance is between 10 and 70. If you're doing intermittent hemodialysis, then supplemental doses should be 30% additional dose if administered after hemodialysis and a 50% additional dose if administered during the last hour of hemodialysis. There are studies, there's one study published in Annals of Intensive Care that looked at the maintenance dose. They've looked at patients who got 9 million units of colistin in a day. They timed that as 9 million units OD, 4.5 million units BD or 3 million units TDS. Now, for the reasons that we've seen earlier, there's no prolonged post-antibiotic effect, and it is area under AUC by MIC as well as concentration dependent. It is not a good idea to ever dose colistin as a once daily drug. There is no preference of giving 4.5 twice daily over 3 times TDS. When we give aerosolized drug, both colistin and polymyxin B can be given via the inhalational route. But the propensity to develop bronchoconstriction is higher for patients when they inhale polymyxin B, thereby most often we use colistin. It is most endorsed in patients who have pseudomonas or drug-resistant infections with underlying cystic fibrosis, but it has also been used as adjunctive treatment for patients with MDR pneumonia. The dosing here is 1 million units for patients less than 40 kilos and 2 million units for patients more than 40 kilos. Bronchoconstriction, cough and chest tightness are the adverse effects, and they can be negated by giving a bronchodilator along with these drugs. What is a toxicity profile? They have both neurotoxicity and nephrotoxicity. Neurotoxicity can be simple in the form of paresthesias, swallowing difficulty, ptosis and weakness, or it can be as severe as neuromuscular blockade with respiratory failure requiring a need for ventilatory support. With nephrotoxicity, there is an increase in the urea and creatinine, decrease in creatinine clearance, hematuria and proteinuria. But the most important thing to note is that whatever the adverse effect, these symptoms are completely reversible and resolve once the drug is discontinued. A little more on the nephrotoxicity of polymyxins, because the scare of nephrotoxicity prevents most of us from using or dosing appropriately polymyxins, which is both polymyxin B and colistin. This has been the study that published in Clinical Infectious Diseases 2013, which compared the toxicity of IV colistin with polymyxin B. All along we have been believing that polymyxin B was more nephrotoxic than colistin, but in this study there was only a 21% nephrotoxicity in patients treated with polymyxin B versus a 40.8% nephrotoxicity in patients treated with colistin. So we probably looking back as polymyxin as a drug with more favorable pharmacokinetic profile and possibly less nephrotoxicity than colistin as opposed to what we believed earlier. The other thing I would like to note here is there are 2 studies published in 2015 that looked at patients who were treated with polymyxin B high doses. And when they say high doses, they used more than 200 milligram per day of polymyxin B versus less than 200 milligrams per day of polymyxin B. And what did they find? It was interesting that when they used higher doses, the nephrotoxicity was high, but the outcomes of those patients were definitely better. And there is a signal from these studies that if we dose polymyxin B at the higher end of the spectrum, we may be causing nephrotoxicity, but when we give lower doses, we are preventing nephrotoxicity at the cost of attaining reduced serum concentrations and thereby causing unfavorable outcomes. Drug interactions, polymyxins should never be given with muscle relaxants because they decrease in acetylcholine release and may cause or aggravate the paralytic action. we should never give cephalothin and polymyxins together because there is a propensity for neurotoxicity. And any antimicrobial agents with a no neurotoxic effect are better avoided with these drugs. A word on the resistance to polymyxins. Resistance develops by an alteration in the outer cell membrane because that is where the polymyxin goes and binds to enter the cell. There is a cross resistance and a high degree of cross resistance between polymyxin B and colistin. Thereby, an organism that is resistant to one will be most likely resistant to the other as well. The other important concept to note here is that of heteroresistance. And this heteroresistance is very pronounced in patients who have Acinetobacter and Klebsiella pneumonia. Now, what we mean by heteroresistance is that there is a population of Acinetobacter or Klebsiella that is very sensitive to a polymyxin. So, we are treating it. But within that sensitive population, there is a small subpopulation. Say there are like 100 bacteria. There are maybe 3 or 4 bacteria that are not sensitive to the drug that we are giving. Once the patient is exposed to these drugs for a prolonged period of time, those mutants, those 3 or 4 organisms rapidly start multiplying and can cause a relapse or a treatment failure. This phenomenon is important for us as clinicians because it is not a good idea to give polymyxins as monotherapy, keeping heteroresistance in mind, especially when the organism you are hitting is an Acinetobacter or a Klebsiella. Now, what are the various polymyxin combinations? Colistin can be combined with rifampicin and a carbapenem, or colistin plus a carbapenem and a sulbactam. Colistin can also be combined with tigecyclines, ceftazidime or glycopeptides or amikacin. I say carbapenem, but it is notable that my earlier speakers always used meropenem in combination with colistin. Now, there is some data to back that. If we are combining a carbapenem with the polymyxin or a colistin, it is always preferable to combine it with meropenem for the simple reason that the molecular size of meropenem is lesser than that of imipenem. So even a small change in the cell membrane permeability makes it more sensitive to the drug that we are giving. And also meropenem is less the development of resistance to meropenem is less dependent on the porins or the efflux pumps. So if we are using a carbapenem, it is preferable to combine meropenem over imipenem. Colistin plus tigecycline can be used for Acinetobacter. Colistin with ceftazidime can also be used. It's interesting to see that colistin can be combined with glycopeptides because we are seeing we are not using polymyxins for fighting gram-positive infections, and glycopeptides are inherently not used against gram-negative bacteria. But in vivo, there seems to be some synergy when a colistin is combined with a glycopeptide. However, there are no clinical studies that say this can be used. It's just an interesting fact that you can take home today. Polymyxin B can be combined either with rifampicin or with rifampicin and carbapenem. There is synergy for both these combinations, but the synergy for polymyxin B and rifampicin is only 50%, whereas it jumps up to as much as 80% when we combine these two with the carbapenem. What is more interesting is this poly B combination with either rifampicin or carbapenem is very active against Acinetobacter and Klebsiella, but not as much against Pseudomonas, unlike with colistin and the other combinations. So this is very important. And the other interesting fact that I came across while I was reading for this talk is that there is poor synergy between colistin and tigecycline, and that is and colistin and rifampin as well. And that was interesting to me because if there is an MDR Acinetobacter, I always thought as colistin plus tigecycline plus rifampicin is a good combination. But we have to keep it in mind that there is a poor synergy between this combination. However, all these are in vitro studies and there are not enough studies done on patients to say one combination is better or is strongly recommended over the other. In summary, polymyxins are the last line therapeutic agents against MDR and XDR bacteria. Colistin appears to have inferior pharmacokinetic properties compared to polymyxin B, but we still use it more than polymyxin B, possibly because there is lack of clinical experience. We need to reevaluate the current dosing regimens, keeping heteroresistance in mind, because we really do not know what exactly is a good loading dose and how often, how much to dose in various conditions. Heteroresistance limits the utility of monotherapy, so please do not give polymyxin or colistin by themselves. Combination therapy helps maximize bacterial killing and prevents development of resistance. Nephrotoxicity and neurotoxicity are the most prominent toxicities, but do keep in mind that both of them are reversible once the drug is stopped. So these are the references I've gone through, and I see that there are neurointensivists. This one thing that I did not include here is both polymyxin B and colistin can be given intrathecally. The dose for polymyxin B when given intrathecally is 5 mg per kg per day pushed. And for the first 3-4 days, it is given once a day. After that, it's given alternate day for 2 weeks. And when we're giving colistin, it's double the dose, which is 10 mg per kg. That is also given for 2 weeks. Thank you so much.